A term baby developed cyanosis after birth, which is not improved with 100% oxygen. So, 100% oxygen was given and a term baby developed cyanosis. So, general, what is the examination? You see, central cyanosis, saturation 65% with 100% oxygen, CVS hyperdynamic apex, pan-systolic murmur best heard over the left sternal border. Chest X-ray shows cardiomegaly with pulmonary oligemia. ECG shows superior axis with right atrial enlargement. Chest X-ray shows cardiomegaly with pulmonary oligemia. ECG shows superior axis with right atrial enlargement. What is the most likely diagnosis? Tetralogy of Fallot, hypoplastic left heart syndrome, tricuspid atresia, transposition of great arteries, and ventricular septal defect. They have chosen transposition of great arteries. A term baby developed cyanosis after birth, which is not improved with 100% oxygen. Tricuspid atresia. This is the same question what we read from the other slide. Newborn with pulse 300 beats per minute with normal BP, normal RR. What you will do for newborn? Newborn with pulse 300 beats per minute with normal BP, normal RR. With pulse 300 beats per minute with normal BP, normal RR, what you will do? There is no option for this. There's no option here for adenosine or for putting ice on baby's face. So you will select diltiazem. Correct patient if unstable. CI in neonate. Okay, child 5 years old had head trauma. Child 5 years old had head trauma. Presents with irregular respiration. Irregular respiration. Most important next step is child 5 years old had head trauma, presents with irregular respiration. Most important next step is intubation. Most important next step is intubation. It is not the CT scan head or mannitol or IV fluids. Child 5 years old had head trauma, presents with irregular respiration. Most important next step is intubation. If heart rate less than 60, we have to start CPR. If heart rate less than 60, we have to start CPR. If in Fallet's tetralogy, the least may occur is, in Fallet's tetralogy, the least may occur is brain abscess is common, endocarditis is common, thrombosis is common, cyanotic HF, heart failure. HF means heart failure. So, child 5 year had a trauma present with irregular respiration, heart failure. Next is 8 years old child with late systolic murmur, best heard over the sternal border. It is late systolic murmur, best heard over the sternal border, high pitch, crescendo, decrescendo. 8 years old child with late systolic murmur. 8 years old child with late systolic murmur, best heard over the sternal border. High pitch crescendo, decrescendo. Diagnosis of systolic regurgitation. Child with tetralogy of palate has tachycardia. Give him propranolol. Child with tetralogy of palate has tachycardia. We will give him propranolol. What is the treatment of child with tetralogy of palate who has tachycardia is propranolol. Child with TOF has tachycardia, tachypnea. Child with TOF has tachycardia, tachypnea, collapsed, but central pulse is good. Tachycardia, tachypnea, collapsed, but central pulse is good. Give him propranolol. Hypercyanotic spell. In cyanotic spell, we give propranolol. Propranolol is given in the cyanotic spell. A child has been receiving high dose of intravenous nitroprusside for several days. He has an uncontrolled hypertension. The following parameters should be monitored. He's using nitroprusside for the past several days. So he has uncontrolled hypertension. The following parameters should be serum BUN, serum creatinine, liver function test, pancreatic enzymes, blood thiocyanate level. They are telling blood thiocyanate level. WPW syndrome, all true except. So in WPW, what happens if there is WPW is associated with Epstein's anomaly? There will be white QRS complex, there will be a delta wave, and short PR, not prolonged PR. Here they are telling prolonged PR. So it is short PR interval. The WPW is characterized by short PR interval followed by a delta wave and a narrow complex tachycardia. But the problem here is this delta wave will make it white. This delta wave will make it appear white QRS complex. And there is short PR interval, not prolonged PR interval. So WPW syndrome, everything is true except prolonged PR interval. So these three we'll read from the other book as well. Child has been receiving high dose of intravenous nitroprusside for the past several days. He has uncontrolled hypertension. The following, what should be checked is blood thiocyanate level. We have to remember that whenever the child is taking intravenous nitroprusside, we have to check blood thiocyanate level. Then WBW syndrome, all are true except prolonged PR. As I told you, it will be short PR, not prolonged PR. So we'll read next three questions. The following conditions are recognized in Sydenham's chorea. Sydenham's chorea will have except. So emotional liability, poor school performance, abnormal movement disappear with sleep, hemichorea. Normal streptococcal infection antibody levels. Normal streptococcal infection antibody levels exclude Sydenham's chorea. So normal streptococcal antibody levels does not exclude Sydenham's chorea. Still, you check the antibody level for the anti-streptococcal antibodies. If it is normal, still the child can have Sydenham's chorea. That means it will not negate you. In the chorea, in Sydenham's chorea, you can see the child may have poor school performance, abnormal movements, disappearing during sleep, emotional liability, and also hemichorea, half of the body with chorea. But normal streptococcal infection antibody levels does not rule out that the child has Sydenham's chorea. Rheumatic chorea or Sydenham's chorea, more in girls more than 8 years, affecting the basal ganglia caudate nucleus. Early onset to late onset, 6 weeks to 6 months after pharyngitis, 6 weeks to 6 months after pharyngitis. Outcome self-limited, resolve within 4 to self-limited, resolve within 4 to 8 weeks without residuals. One more thing, Sydenham's chorea is a self-limited condition which resolves within 4 to 8 weeks without residual manifestations. Emotional instability, sudden crying, laughing, involuntary movements, sudden jerky, spontaneous, involuntary, symmetrical, all S, sudden, spontaneous, symmetrical, pseudo-purposeful, increased by stress, reduced by sleep. You have to remember this Sydenham's chorea increased by stress and reduced by sleep. Sudden fall of objects from hands. This is upper limb, lower limb, unsteady gait, classic chorea. Face, grimace, one side of the body, hemichorea, tongue, speech interruption, respiratory muscles, chorea gravis, hypotonia, hyporeflexia, darting dog tongue, abnormal Vermeyen movements of the tongue when protruded. This is called darting dog tongue. Milkmaid sign, irregular contraction and relaxation on squeezing examiners, irregular contraction and relaxation on squeezing examiner finger. Choric hand, can't maintain extended arms, dinner fork hands, piano player, pronator signs, paralysis, choreatic paralysis, and severe hypotonia, choreal monosis. All these are the manifestations of Sydenham's chorea. Next is, we conclude that mitral valve prolapse. We conclude that mitral valve prolapse is 4 times more common in patients with severe idiopathic scoliosis than in normal adolescent population and is associated with lower body weight and IS patient with MVP and is patients without MVP. Severe idiopathic scoliosis is associated with mitral valve prolapse. Indication for hospital admission is cyanosis. Cyanosis. Indication for hospital administration in idiopathic scoliosis with mitral valve prolapse is cyanosis. Drowning case. Resuscitated for 30 minutes. Drowning case, you resuscitated for 30 minutes with no response. Asked to stop CPR, what to do? CPR till temperature reached, that is, till temperature reached. Rapid rewarming of the patient, IV saline, stop CPR. Okay, drowning case, you resuscitated for 30 minutes with no response. And they asked you to stop CPR. So the next step is rewarming of the patient. The next step is the rapid rewarming of the patient. Congenital heart disease in children is all except you'll have gallop rhythm, yes, bounding pulse, yes, basal crepitations, yes, periorbital edema. Periorbital edema you see in glomerulonephritis and nephrotic syndrome, not in congenital heart disease. So congenital heart disease in children can present with bounding pulse, basal crepitations, and gallop rhythm. So we'll repeat the 3 questions from this other book. Mm. Indication of hospital admission is cyanosis. Indication for hospital admission, most top will be cyanosis. Drowning case, resuscitated after 30 minutes with no response, asked to stop. Rapid rewarming of the patient is very, very, very important in drowning. Congenital heart disease in children, except all. You don't see periorbital edema usually in congenital heart disease. Congenital heart disease in children will cause gallop rhythm, bounding pulse, basal crepitations. Left ventricular hypertrophy occurs in all except left ventricular hypertrophy occurs in all except coarctation of aorta. Let's do some drawing now. Coarctation of aorta means there is some narrowing of the aorta. Coarctation of aorta, there's narrowing of the aorta. So there will be working of the left ventricle, which will make it big. In tricuspid atresia, again, the right heart is weak. The tricuspid valve and the right heart is weak. So you will have this. So the left ventricle will be strong even in this case. But in transposition of great arteries, what happens? Aorta starts from right ventricle and pulmonary artery starts from left ventricle. So the left ventricle will be weaker here. So the transposition of great arteries is the correct answer. A child with cyanotic congenital heart disease presents with a child with CHD presents with vomiting, weakness of right arm and leg. What's your diagnosis? So definitely cyanotic congenital heart disease, maybe this is tetralogy of Fallot, who is presenting with weakness of right arm and right leg, means this is hemiplegia. The cause will be brain abscess, thrombosis, embolism, rupture Benny aneurysm, or it can be thromboembolism, anything, thrombosis or thromboembolism. Left ventricular hypertrophy occurs in all except TGA. TGA will have right ventricular hypertrophy. So, which are the conditions which will have right ventricular hypertrophy is the transposition of great arteries and tetralogy of Fallot. Okay, child with cyanotic congenital heart disease present with vomiting, weakness of, what is your diagnosis? Thrombosis. This is cerebral thrombosis. Okay, complications of ventriculoatrial shunt. One answer is wrong. Complications, all the complications of ventricular atrial shunt or shunt nephritis, infective endocarditis, shunt infection, yes. Slit ventricle syndrome, yes. We don't see acute fulminant hepatitis. We don't see acute fulminant hepatitis. Complications of ventriculoatrial shunt or shunt nephritis. Yeah, ventriculoatrial shunt can cause shunt nephritis. Infective endocarditis, shunt infection, but acute fulminant hepatitis is not the complication. Slit ventricle syndrome also no. So they can have shunt nephritis. Ventriculoatrial shunt can have shunt nephritis, can have infective endocarditis, shunt infection, and slit ventricle syndrome, but not acute fulminant hepatitis. Child after car accident. Child after car accident, GCS low. Child after car accident, GCS low, heart rate 60, respiratory rate 8. So respiratory rate 8 is very low. That means the child is gasping. Child after car accident, GCS is very low. Heart rate is 60. Respiratory rate is 8, means the child is gasping. So he needs urgent intubation. Urgent intubation and mechanical ventilation. CPR also can be considered if heart rate less than 60. So mechanical ventilation is the answer. One-year male case of ventriculoseptal defect. 1-year-old case of ventricular septal defect. One-year male case of ventricular septal defect. CHF. Congestive heart failure, weight 6 kg. What's the management? So congestive heart failure, what we do? Oh no. Treatment of congestive failure and urgent surgery. Yeah. 1-year male case of VSD and congestive heart failure, weight 6 kg. So first we will correct the congestive heart failure. This is very important. First we will correct the congestive heart failure, then we will go for an surgery. Let's see. 1-year male case of VSD and congestive heart failure, weight 6 kg. Treatment, we have to treat the congestive heart failure first, then we have to offer for an urgent corrective surgery. That means we cannot wait for up to 8 kg, or we cannot discharge the patient and surgery later, and treatment of congestive heart failure, prepare for surgery, no. Correct, and then take for an urgent surgery. Next question. An ill-appearing 2 weeks old girl. 2 weeks old girl is brought to emergency room. She is pale and dyspneic. She is pale and dyspneic with respiratory rate of 80 breaths per minute. Heart rate is 195 beats per minute, and her sounds are distant and gallop is heard. Gallop means the child is in heart failure. Her respiratory rate is 80. Her heart rate is 195. Sounds are distant and gallop is heard. There is cardiomegaly by an X-ray. An echocardiogram demonstrates poor ventricular function, dilated ventricles, and dilatation of the left atrium. dilated ventricles, dilatation of the left atrium, and electrocardiogram shows ventricular depolarization, complexes that have low voltage, ventricular depolarization complexes that have low voltage. The diagnosis suggested by this clinical picture is myocarditis, but 2 weeks old में myocarditis होता है, हो सकता है. So 2 weeks old, there is heart failure, that means gallop, cardiomegaly by X-ray, respiratory rate 80 breaths per minute, heart rate 195 per minute. Echocardiogram demonstrates poor ventricular function, dilated ventricles, dilatation of left atrium. Echocardiogram shows ventricular depolarization complexes that have low voltage, and diagnosis is suggested by this clinical picture, that is myocarditis. Four-year old child have car accident. Four-year old child have, okay. 4 years old child have a car accident. The GCS is 5, heart rate 52, respiratory rate 8. What to do? CPR. We have to do CPR. And all. Heart rate less than 60 in CPR, and also mechanical ventilation. Both CPR has to be started and try to intubate and mechanically ventilate. Go step by step. CPR has to be started, then try to intubate, then mechanically ventilate the patient. So heart rate is 52 can be, heart rate 52 can be bradycardia algorithm with cardiopulmonary compromise. If there is bradycardia with cardiopulmonary compromise, we do CPR, then intubation. But heart rate 52 with raised intracranial pressure and BP high, raised increased intracranial pressure and BP high with good pulse. Heart rate is 52, but the pulse is good. No need to do CPR, because since the child respiratory rate is 8, you will intubate with rapid sequence intubation and brief hyperventilation. So heart rate less than 52 has two things. Bradycardia with weak pulse, that is cardiopulmonary compromise, you will go to CPR and intubation. If bradycardia with very good pulse, high BP, high increased intracranial pressure, you will go for intubation, rapid sequence with brief hyperventilation, no CPR. So depending upon the scenario given, you have to decide. Least prognosis in a child near drowning. The least prognosis in child with near drowning is absent brainstem reflexes more than 24 hours, absent purposeful movement for more than 24 hours, core body temperature less than 32 immediately after immersion. So, poor prognosis. What are the cases of poor prognosis in near drowning is absent brainstem reflexes for 24 hours, absent purposeful movement for 24 hours. Absent brainstem reflexes for 24 hours, absent peripheral movement for 24 hours, core body temperature less than 32 immediately after immersion. So,